in one of the time that we felt superior to radiology because like we told him, I think you missed something. Maybe you can scan him again.
Okay, so we're going to move on to the evidence part. So again, the point of care ultrasound summary of evidence document is great for summarizing the literature in terms of applications for POCUS. So they have a section on appendicitis, and in terms of the adult evidence, one of the first studies was done by Chen et al. In 2000. Interestingly, they found a high sensitivity of 96% and specificity of 68%. First, and they concluded that accuracy of 89% is higher than surgeons' clinical accuracy of 71%. Then there was another study by Fox et al. In 2008 that showed lower sensitivity but high specificity of 90%. They concluded that maybe the sensitivity is a little bit too low to recommend this as a screening test, but perhaps if it's positive, then you may be able to get away without the CT scan. In terms of the pediatric literature, in the radiology world, the sensitivity quoted ranges from 50 to 100%, and specificity is 88 to 99%. The ultrasound sensitivity was quoted to match CT when the symptoms have been going on for longer than 48 hours. Presumably, you would have more findings. The secondary signs, the bigger appendix makes it more sensitive of a scan. And in 2011, they advocated for this Sono first approach, where you do a staged imaging strategy, where you do ultrasound as the initial imaging study, followed by the CT only in the equivocal cases. So now typically we do most of our diagnoses is on ultrasound. We very rarely have to go towards CT. In terms of the pediatric PEM literature, this is one of the papers that's quoted the most. So Adam Sivitz in 2014 did a study involving 264 scans. 32% of these kids had pathology verified appendicitis. The mean age was around 10 years old. The scanners include one very experienced faculty who trained 12 PEM fellows with 45 minutes of lecture and 5 practice exams. And they found that the sensitivity was 85% and specificity was 93%. So it had really good performance. The only caveat is that 43% of the scans were done by the experienced faculty. So that we should take that result with a grain of salt and just keep in mind that there may be some user variability depending on the training of the point of care ultrasound user. Here's another study by Elikashvili et al. They looked at 150 pediatric patients. They were interested in looking at the length of stay and CT utilization when they're able to use point of care ultrasound. So they also found a significant decrease in ED length of stay when POCUS is performed compared to requesting the radiology ultrasound. And they also had good performance characteristics with sensitivity of 60% and specificity of 94%. And they found that the decreased length of stay didn't lead to any cases of missed appendicitis. This is a meta-analysis that was discussed a lot. It came out in 2017. It included 21 studies with an N of 8,600 patients, 39% of which had appendicitis. And it was meta-analysis that looked at various different things like history, physical exam, laboratory testing, and point of care ultrasound to see which features performed the best in terms of correlating with acute appendicitis. And they found that the most associated features were a history of pain migrating to the right lower quadrant and cough or hot tenderness in the undifferentiated abdopain group. And then in the group where they suspected appendicitis, the Rovsnick sign on exam was the most associated feature. PAS score of above 9 also performed well, and ED POCUS also performed well. In terms of the sub-analysis involving the ED POCUS group, there were 5 studies that met inclusion criteria. 4 were pediatric. One by Fox et al. Was mixed adult and pediatrics. And the sample size ranged between 40 to 264. They also found good performance characteristics with sensitivity of 86%, specificity of 91%. They concluded that positive ED POCUS is diagnostic, whereas negative ED POCUS is not enough to rule out. So this is a study that endeavored to look at the cutoff of 6 millimeters in kids. So the population was between 2 to 18 years old, a retrospective chart review where they looked at should it be 6 millimeters, should it be 7 millimeters, and they actually found that 6 millimeters had an excellent sensitivity but poor specificity. So it was up to 100% sensitive, but only 43% specific. So we may be overcalling a lot of appendicitis if we're using 6 as a cutoff. Versus if we use 7, your sensitivity becomes a little bit less at 94%, but your specificity improves to 71%. So there's some other study that's ongoing right now that's looking at this threshold to see if we should change it from 6 or 7 millimeters. But sometimes you just don't see it. So this is an example that of a study that looked at non-visualized appendix on ultrasound and what that actually means. So this involved 641 pediatric patients where 160 of them didn't see the appendix. But then when there was positive secondary signs, it still performed very well, even when you don't see the appendix, with sensitivity of 82%, specificity of 99%. So they concluded that non-visualized appendix without secondary signs, the likelihood of appendicitis is very low at less than 2%. And this table 2 within the study just highlights that, that even when it's a non-visualized appendix, it still performs relatively well. Now, just to finish up, we're going to discuss some pitfalls and pearls. So the appendix is hard because there's so much bowel content around. Sometimes normal small bowel can be confused as appendix. Sometimes you may not see it. Sometimes you may have false negatives because you see part of the normal appendix, but you're not able to follow it to the tip, and sometimes you may miss tip appendicitis. You could also have false positives where you're calling something appendicitis when really it's just inflammation related to another intra-abdominal process like Crohn's or PID, etc. So ways to kind of work around the difficulties of the POCUS appendix scan is using this graded compression technique so that you can displace some of that artifact from the gas or the overlying bowel. There's also this posterior manual compression technique where you can just slide your left hand underneath the patient and just bring, just apply anterior pressure and just try to bring the cecum area closer to your probe. And that can sometimes bring it into view. You really want to sweep the entire abdomen so that you look for the non-classical locations and also for secondary signs. You want to choose the right patient. So if the patient is an obese teenager, it may not be the best investment of your time because it may take a long time to be able to do the scan. You really want to get to know your anatomy so you know what you're looking at, and practice always will make it easier for you going forward. So those were our objectives today. We went through how to perform the appendix scan, reviewed lots of case examples, abnormal versus abnormal, reviewed some key literature, and discussed some pitfalls and pearls. So here's the link again for you to sign in and to do evaluations. And here is my contact information. We have our YouTube channel that these screencasts gets posted afterwards. And on Twitter, we often post our interesting scans. So thank you.